So now we return to the heart. The capillaries have done the exchange, and we've delivered what we needed to the cells, and the cells have dumped their waste back into the tubes. So we start off, after leaving a capillary, as a venule. And so we're getting a little bit larger, and we see these cartoon here to kind of look at the difference between the venule, the medium-sized vein, and large veins like the superior vena cava and inferior vena cava. So in the beginning, the venules look a lot like a capillary. There is a very thin tunica media and tunica externa that hold the tube together, right? Veins are somewhat porous and permeable, which is good because we're trying to recover any fluids, right, that were pushed out in the arterial end. So we have this a little bit more porous, a little bit more, leaky in that sense, but it's such low pressure that it's the interstitial fluids push it into the venules. And the true goal here, of course, is reabsorption of fluids and get them back to the heart, because you only have so much blood volume, and it's going to help us generate our blood pressure. All right? So here again, same cartoon. We always have a thinner walls in our veins. The lumen is always larger. They have very low pressure in them, right? We left off in the capillaries at somewhere probably around 17 millimeters of mercury, so pretty low after leaving the heart at somewhere around 95, and it's just going to keep dropping. So I mentioned here that the tunica intima has valves. That's a modification to help keep that blood going back, and valves always help us keep blood going in one direction. Tunica media is a smooth muscle here, and it does respond to the sympathetic, the autonomic nervous system, but it isn't as well developed as it was in the arterioles. And the externa is actually the thickest of the three tunics, in whether it's a medium-sized vein or a large vein. Lots of collagen here and elastin, which means that veins they're stretchy and flexible. All right. This is a nice table to remind us that again, you have 5 to 6 liters of blood in total. How are you going to divide it up? So again, here's the gross divisions, with heart obviously receiving a good amount for such a small part of our overall body, but lots of it out in the systemic, a little bit less in pulmonary, right? And then we break it down. So pulmonary, capillaries, arteries, and veins are about equal, but in the systemic, right, the veins clearly have a whole lot more. And so we say that the veins are blood reservoirs, right? So again, veins have all that elastin in them, so they're very stretchy, so they can accommodate this extra fluid. And then as soon as you become active, blood can easily be pushed back to the heart and redistributed through the body accordingly by just constricting that tunica media, right? So this is going to help us when we need to increase our end diastolic volume, right? Venous return. So it's something to consider here. These are measures we want to know about when we talk about the blood vessels. So I've said this a couple times, but just formally defined here what flow is, right? It's an amount that's moving over some time period, all right? And I said flow is really started by the ventricles, and it really is the same thing as what we talk about as cardiac output. Pressure, of course, is how much force is being exerted on a container. And this is really occurring here because of the blood, the amount of blood that's in there, and a few other things as we talk about the different variables that affect pressure. Pressure is always from high to low. I mean, we call that a pressure gradient, but we know with pretty much certainty that if there's more pressure in the tube, there will be more flow. Resistance, then, is what the word says. It's going to kind of slow down. It's going to impede some of this movement. And so the reason for resistance, of course, is that flow has to be appropriate to meet the needs of the tissues, and you cannot have so high a flow that you rupture the tubes, as we talked about, pressure dropping as you got to the capillaries, and it dropped because resistance increased with the lumen of the vessels getting smaller and smaller. So a take-home here, of course, is that pressure drives blood and resistance slows it. All right, so here's a tracing right, of your overall pressure, right? And this we are identifying as a pulse pressure, and that is the difference between systolic and diastolic. And here, of course, close to the heart, it's very easily, you can easily see the pulsatile nature of pressure going up as the heart contracts and coming down when it relaxes, up and down, up and down. So again, the mean is what I've been talking about all along when I say 17 or 95, your mean arterial pressure, because it's cleaner to use one number as opposed to this number over that number. All right, so here I mentioned that when the ventricles contract, they actually transfer some of their energy of movement, kinetic energy, to the blood. So when they contract, it's going to cause the blood to move. Well, and what happens is, as the blood is pushed into the smaller arteries, the aorta or the pulmonary artery, the artery will stretch. And this is very much like what happens with a rubber band, where you put effort into stretching it, so you become the ventricle and the stretch is the aorta. And we hold for a short period there, very short, and that high pressure is systolic. The valves close, semilunar valves, and the high pressure that was transferred to the vessel and the blood drives the blood outward. So that's kind of like letting go of that rubber band. All right? So as the ventricles relax, diastolic pressure is measured, and flow continues, but it is at its lowest pressure. All right? So again, pulse pressure is defined as systolic minus diastolic. All right? And then mean arterial pressure, which is shown here, is actually the diastolic plus 1/3 of the systolic minus diastolic, which in this case is 40. And so on average, your mean arterial blood pressure is somewhere around, I would say, about 92 to 95 at rest. Right? And again, if this goes below 60, then we have a situation of ischemia, hypoxia, which can lead to death. And so you go into shock when that mean arterial blood pressure drops too low. All right, you can feel these events, of course, as a pulse, and the pulse is really due to this expansion, all these elastic fibers in the arterioles and arteries and arterioles, is it causing the expansion with the force, systolic force being transferred. And then when the heart relaxes and force decreases, the vessels recoil, and so you feel an alternate expansion and recoil that we call the pulse. Right? So I say measuring this force of movement, which was what we call blood pressure, and I said, this is probably the most commonly measured thing in a person clinically, temperature and blood pressure. All right? So we want to think about what are the things, what does blood pressure mean again, and what things influence blood pressure. So I say here, when you do a measurement of blood pressure, it relies on these name for person, Korotikoff sounds, which is due to turbulence in the blood vessel as it's been compressed. So what happens in a blood pressure is you increase the pressure in the cuff, known as the sphygmomanometer, and to a point that collapses the artery. So you have to go above the pressure that's actually in there. Generally, if we assume at rest they're 120, you have to just go above that, maybe 160 or 180, right? And you shouldn't hear anything in the vessel because there isn't any flow going through. But as you release the pressure in the cuff and it starts dropping, well, then the force that's in the blood vessel will actually allow the blood through. And that's when you hear the Korotikoff sounds. All right? Factors that influence blood flow and blood pressure, well, cardiac output is definite, right? If stroke volume goes up, you'll see blood pressure go up, you'll see flow go up. If heart rate goes up, blood pressure goes up and flow goes up. And again, flow is really the same thing as cardiac output, so we know since cardiac output is stroke volume times heart rate, that truly makes sense. Okay? Compliance is how much the vessel will stretch, and so how much will the vessel work with the heart as it's pushing the blood in there. All right? Blood volume, so if for some reason you increase or decrease the blood volume overall, then we would see an increase in blood flow with an increase in blood volume and an increase in blood pressure. All right? Blood viscosity, so if blood gets thicker, that's going to affect blood pressure. All right? blood vessel length and width, so really how far does the blood have to travel and through what size of tube. So I say here that the heart provides a pressure and the vessels work to keep this going without being damaged. And this goal, the overall goal is, right, make sure you meet the tissue's needs with the amount of blood flowing. All right? So we model these relationships, and I'm not going to ask this on a test. I'm really not. I mean, your book is very good, and these are important for people clinically. And your PhysioX exercise even uses this same equation. Holes doesn't mention it, which is a shame, because like I said, it's really good to understand that the heart is so, we actually know how it works so well that all we have to do is plug in different numbers, right? So I said if the length goes up, right, over here, viscosity here, right? We plug in different numbers and we see what happens to blood flow, right? So overall, again, I say here, this allows us to predict the effects, including those of drugs. If we treat a patient, we want to know that we're going to get the outcome we expect. So the vessel's effect on blood flow is a fluid mechanics, basically, or hemodynamics. And it really depends on how wide the tube is, which we're just going to say radius, I suppose, diameter, and how far the blood has to go, and what the overall thickness of that is. And this, in this slide, again, I just break it down to what all these terms mean, but I'm not going to ask you about those. You should know that radius, length, and viscosity influence blood flow. And this just shows the relationship of these, all right? So if resistance becomes a problem, well, then flow is going to be compromised, right? If you have to go farther, flow is going to be compromised. If there's a smaller tube, flow is going to be compromised. So I say to you this also, as I walk you through here, helps us calculate resistance, which is what we mentioned on the previous slide, was an important variable along with flow and pressure. And I say this is because, right, that resistance is inversely related to flow. Again, what this is saying mathematically is if resistance goes up, flow will go down. So smaller tubes mean less flow, right? If pressure has a direct relationship to flow, so if pressure increases, flow increases. All right? And just repeat it here. And I said, you realize that if, again, resistance increases, flow decreases. So we need to know what changes resistance because we need to match flow. So I said, again, we can rearrange this into resistance equals, just rearranging the equation. Then substitute the equation for blood flow. And here's the bottom line, right? Radius is the most important predictor of resistance, and it has a big effect. That's what we're seeing mathematically. And you also test this in a PhysioX exercise you do. And so, again, if your radius decreases, right, then you have greater resistance, and therefore your flow is decreasing. And that's a problem. It's also a solution. If you think about it, it depends on how we're applying it. So it's a problem if you have plaque or something built up on the wall and the radius gets smaller and smaller. But it's a solution when we talk about, the transfer of blood and decreasing pressure and flow going from an arterial to a capillary. All right, blood volume, another metric we said has an influence on pressure and flow. All right, I said this is really probably not going to change, right? You have 5 to 6 liters. What's going to change is where it goes and where you'd find it at any given time, right? And I say even if you increase blood volume, your kidneys are going to reestablish your homeostatic constant, right? So here, pressure is directly related to volume. Again, the more volume you have, the greater the pressure. And this is why, conversely, if you lose blood, hemorrhage, pressure drops, right? If you increase blood, you increase pressure, all right? So increase volume, increase pressure. Hormones, yes, stabilize these things. So when you lose blood or have a pressure drop, renin-angiotensin 2 an antidiuretic hormone, and aldosterone all work together. So please think of them together. Right? They're a solution to a problem of low blood volume or blood pressure. If it's high, we use a different hormone here. Atrial natriuretic peptide and ventricular natriuretic peptide will be the solution to a problem of high blood volume and high blood pressure. We'll pick this up on the next video, and please bring any questions.